So our next presentation is on, again, a related topic, just on this ART eligibility at enrollment and time to ART initiation in Ethiopia. And the presenter is Dr. Dale, Senior Project Officer at ICAP and Advanced Doctoral Student in Department of Epidemiology at Mullivan School of Public Health, Columbia University. I think she's going to present you some very interesting findings which might be in contrast to the previous presentation.
Yes, thank you very much. And thanks to the organizers for inviting us to present our data on antiretroviral therapy eligibility at enrollment in HIV care and time to treatment initiation in Ethiopia. So as we all know, there are about 12 million adults and children receiving ART in low and middle income countries. We also know that timely initiation of ART is critical before advanced disease status, as late ART initiation is associated with increased morbidity and mortality. In light of these data, the WHO have revised guidelines in 2010 and 2013 to raise CD4 eligibility thresholds. This graphic shows the steps in the HIV Care Cascade leading up to ART initiation, which include HIV testing, linkage to HIV care, assessment for ART eligibility, and immediate access to ART initiation for those who are eligible, as well as routine monitoring for those who are not eligible at the time of enrollment, leading to ART initiation eventually. We know that only about 65% of patients who are eligible for treatment in low-resource settings are initiating ART, and many are lost and die before they can start treatment. Retention and monitoring of patients who are healthy at the time of enrollment is challenging for programs. About half of patients who are healthy at the time of enrollment are lost before they reach eligibility. The purpose of our analysis was to examine pre-ART outcomes of adult patients based on their ART eligibility status at the time of enrollment in HIV care. We examined the incidence of reaching ART eligibility for patients who were not eligible at the time when they enrolled in care. We also assessed the incidence of ART initiation for patients who were eligible when they enrolled in care and for patients who were not eligible when they enrolled but became eligible during follow-up. We also assessed the factors associated with ART initiation. For the analysis, we used routinely collected data from ICAP-supported HIV care and treatment sites in Ethiopia, and these data come from the Identifying Optimal Models for HIV Care in Africa study. In the analysis, we included all adult patients 15 years and older who enrolled in HIV care between 2006 and 2011 at 45 Ethiopian health facilities in 4 regions. All patients were grouped according to their ART eligibility status at enrollment, assessed using CD4 and WHO stage. For the analysis, we looked at 3 patient groups: patients who were eligible for ART at the time when they enrolled in HIV care, according to Ethiopian national guidelines; patients who were ineligible for ART when they enrolled in care, according to national guidelines; and patients who were indeterminate, meaning they lacked sufficient data to determine their ART eligibility when they enrolled in care. We then used follow-up visit data to assess when patients became eligible for ART and when they initiated treatment. And you can see here the Ethiopian National Treatment Guidelines, which remained stable during our analysis period. So for the analysis, we were interested in these 2 time periods, the first being from a time of enrollment in care to ART eligibility, and this was assessed for patients who were ineligible for ART at enrollment and patients who were indeterminate at enrollment. We then looked at time from ART eligibility to ART initiation, and this was looked at for all patients who were eligible when they enrolled in care and for those patients who became eligible during follow-up. Competing risk estimators were used to calculate cumulative incidence, and competing risk regression was used to assess the factors associated with ART initiation. We included over 73,000 adult patients in our analysis, about half of whom were eligible for ART when they enrolled in care, according to Ethiopian national guidelines. About 36% were ineligible for ART when they enrolled, and 13% were indeterminate, again, meaning they lacked sufficient data at the time of enrollment to assess their ART eligibility. Compared to the ineligible and indeterminate patients, the eligible patients were slightly older, they were more likely to be male, they were also more likely to enroll at secondary and tertiary facilities as well as urban health facilities. In the first part of the analysis, examining time from enrollment to ART eligibility, we found that at 12 months after enrollment, 23% of patients who were ineligible when they enrolled in care had become eligible for ART. We found that 35% of patients who were indeterminate when they enrolled in care had reached ART eligibility by 12 months. In the second part of the analysis, time from ART eligibility to initiation of treatment, we found that 66% of patients who were eligible when they enrolled in care initiated treatment within 1 month. 47% of patients who were ineligible at enrollment started treatment within 1 month of reaching ART eligibility, and 66% of patients who were indeterminate started treatment within 1 month of reaching eligibility. At 3 months, the proportions have gone up, and finally at 6 months, we found that 82% of patients who had enrolled eligible for treatment had started ART. 64% of patients who were ineligible in enrollment started ART within 1 month of reaching eligibility, and 81% of patients who were indeterminate when they enrolled and reached eligibility started ART within 1 month. Here we can see the median CD4 count at enrollment and at ART initiation for the 44,000 plus patients in our cohort who had CD4 at enrollment and at ART initiation. And we can see that CD4 increased significantly from 2006 to 2011 overall. However, ART initiation CD4 did not increase during this time period. If we look at median CD4 count at enrollment and ART initiation based on ART eligibility status at enrollment in care, we can again see that among the patients who enrolled eligible for ART, CD4 counts were low at enrollment and at ART initiation and did not increase during the time period. However, there was a significant increase in enrollment CD4 for patients who were not eligible when they enrolled in care. So we can see that healthier patients over time are being enrolled in care. We did not see an increase in median CD4 at ART initiation among ineligible patients, but this would be expected given that the ART guidelines in Ethiopia did not change during this time. With regard to the factors associated with starting ART, among all patients who were eligible, we found that older age and lower CD4 count were significantly associated with initiating treatment. The major strength of our analysis is the use of routine HIV care and treatment program data. These data were not collected in the context of a study, they were collected as part of routine care, and so they're highly representative of the care that patients were receiving. We also have a large cohort of over 73,000 adult patients. However, we are missing CD4 data on about 40% of the cohort at enrollment, but most patients did have WHO stage data at enrollment. We also don't have data on the individual provider and patient reasons for why treatment may not have been initiated. And we only have data on those patients who were retained in care. We don't know the outcomes of the patients who were lost to follow-up. However, we do know that loss to follow-up is differential based on health status at enrollment, with patients who are not eligible for ART being more likely to be lost. In summary, we found that many patients in this Ethiopian cohort who were eligible for ART when they enrolled in care started treatment rapidly within 1, 3, and 6 months. Patients who were ineligible for ART and enrollment and reached eligibility did not start ART as rapidly. Only 64% of patients who were ineligible when they enrolled started ART within 6 months of reaching eligibility. We also saw that many patients are still enrolling and starting ART with very low CD4 counts, as indicated, with advanced disease status, as indicated by low CD4. So in conclusion, we would say that Ethiopia has achieved great success in scale-up of HIV testing, care, and treatment services. However, greater efforts are needed to ensure continued retention and monitoring of patients, to ensure that they are identified when they become eligible for treatment, to ensure rapid initiation of treatment for those who are eligible, and avoidance of late start of ART initiation. We do think that because new guidelines have been adopted in Ethiopia, in 2012 they went to the WHO 2010 guidance, so we think that this will probably have an impact on the number of patients starting at advanced disease status. Thank you very much for your attention, and a special thanks to the patients and staff and ICAP team in Ethiopia. Thanks.
The session is open for questions. Yeah, yes.
To make a comment, in fact. I think this is a very nice presentation for two reasons. There's a lot of discussion about ditching CD4 count and do only viral load. And I would like to argue that this presentation gives a very nice illustration how you can use CD4 count to assess the ability of your patients to capture the patients you really want to enroll. Unless you have this information, you do not know how efficient you are in enrolling your target population. So, and this is something that we need to keep in mind when we discuss whether to continue investing in CD4 count. Now a question. You mentioned differential loss to follow-up rate. Do you know what the differential loss to follow-up rates are between your eligibles and non-eligibles and indeterminates?
We do have those data and we are analyzing them. I can say that the loss in the period between enrollment in care and ART eligibility was much higher than between ART eligibility and ART initiation. So that is the loss as would be expected. I don't have those data to present here, but it was fairly significant. It was around 30 to 40% in the first 12 months after enrollment for ineligible patients. But we'll be presenting those data elsewhere.
I think we have a question. Podium 3.
Thank you. My name is Alina. I'm just wondering whether you in any way utilized sites for TB treatment as sites for recruitment and what kinds of integrated programs you have with respect to TB and HIV/AIDS treatment. And then secondly, whether in terms of recruitment, you also did follow-ups for partner testing so that you have a greater pool of people in terms of family-based testing and support thereafter. Thank you.
Those are great questions. Again, we use routinely collected patient-level data from these sites in Ethiopia, so we don't have a lot of qualitative factors about the programs. Ethiopia has made great efforts at expanding treatment, testing partners, provider-initiated testing, but we didn't look at any of those factors. They certainly would be very interesting to examine.
Yeah, please.
Thank you for a nice presentation. Do you know, in Ethiopia, who actually gets into care? Is everybody who's tested enrolled into care? Do you know the rates of enrollment into care of people who test positive? I'm just trying to put this in context.
Right. It's, again, a very good question in terms of are people falling out of the cascade before they even get into HIV pre-ART care, as we might call it. I don't have those data, but it would be a very interesting question. We don't have the information on what proportion of the patients who tested positive enrolled in care. Sorry.
I think it is very important for countries to develop a mechanism of retention cascade measurement every year. We have introduced this in India 2 years. Out of all those who are tested positive, how many are enrolled, how many are eligible? Out of that, there is a leakage at every step. But once we know the leakage, we have a mechanism for every step. And we have defined interventions that can be done at the LFU stage 1, 2, and 3. What interventions can be made to reduce right from testing to enrollment even. Still, in our program also, around 14% of the people who are eligible do not enroll, actually get initiated on ART. That is one area where a new initiative has been taken in the Citizen Charter. We have put it in that all eligible patients, 80% of them should be initiated on ART within 60 days. And that is a Citizen Charter. Anybody can basically ask the program where are the other patients who have been lost to follow up. So some kind of initiatives we need to bring in so that we can plug the leakages at the retention cascade. Thank you very much.